These are my disclosures. So my focus will be on pretty much intravascular ultrasound. I'm not going to go into different kind of imaging at this point. So just to put things in perspective, we have a lot of options, of course, to treat tibial disease in CLI patients. You see the whole list, which is a good thing, by the way: angioplasty, stenting, atherectomy, shockwave, a lot of specialty balloons, of course, bypass surgery, and for those with no option disease, deep venous arterialization. Like Dr. Mustafa have published this paper to tell you what kind of disease we're dealing with. If you look at those patients, a lot of diabetics, mostly CLI, a lot of total occlusion, severe calcium is highly prevalent, and very long lesions. So again, unfortunately, all our therapy with PTA right now just leads to a very high loss of patency, a lot of repeat revascularization, major amputation, and death is still pretty high. So we have suboptimal results. And we know, for instance, bare metal stenting really does not yield too much beyond angioplasty. This is a meta-analysis that demonstrate that. The only thing we know is like drug-eluting stents for short segments have a better patency rate, maybe do better when it comes to TLR, and restenosis, possibly improving the risk or lowering the risk of amputation, but no alteration for mortality overall. And we know very well that there is very much a lot of limitation when it comes to drug-eluting stents currently as they exist with the short balloon expandable stents. Again, for DCB versus PTA, I think, to the most part, we don't have a whole lot of biological effect despite some positive data that we're seeing lately. But with randomized core lab data, we're not seeing a whole lot of response for below the knee. So question is, why is that? Are we really looking at the wrong type of intervention, or are we looking at the vessel in the wrong way? And I think angiography has several limitations. That's what we use predominantly. Number and severity of dissections, including deeper injury, is very much underappreciated. Residual narrowing post-intervention is not appreciated well. Vessel sizing, clearly undersizing, with angiography. Plaque morphology, severity of calcium, intraluminal thrombus, stent expansion, symmetry, apposition, intraluminal wire positioning. We don't even have a classification, when it comes to angiography, to have a unified way that correlate with intravascular ultrasound. In fact, just recent data showing the Kobayashi and the NHLBI classification both have absolutely no correlation with intravascular ultrasound findings. Bottom line is precision imaging is important to improve what we are getting right now with tibial intervention. Accurate vessel sizing, assessing residual narrowing, defining plaque morphology, including calcium, the presence and the severity of dissections, the stent expansion and symmetry, and intraluminal crossing are very important when it comes to precision imaging. And the angiogram simply is not a fair way to perform all these functions. So if you look at an example, for instance, here for a CTO crossed, and this is not tibial, this is femoral, but I'm going to show you similar things in the infrapopliteal territory. And you can look after laser and balloon angioplasty, beautiful results, on the angiogram. If you look at the IVUS, you can see the amount of residual narrowing that is left behind, tremendous amount of residual narrowing. And the question, how does that impact, your results down the road? Beautiful acute results, still a lot of things left behind. If you look in the infrapopliteal segment, exactly the same thing. Vessel sizing here is highly underappreciated, by the angiogram. In fact, on average of about 1 to 1.1 millimeter difference. And this is core lab adjudicated, publications showing that we invariably undersize our balloons when it comes to the infrapopliteal territory. And this is exactly duplicated in a publications. At the same time, almost simultaneous publication showing that when you use digital subtraction angiography and compare it to intravascular ultrasound, also we have about a 1 to 1.3 millimeter, undersizing, when we deal with the tibial vessels. The eye dissection classification came as a classification mostly to determine the depth and the arc of dissection, because the depth can determine a lot of your long-term results. The flaps or the intimal flap can affect your acute results in many ways. And in fact, in this type of classification, you can see that the intima, media, and adventitia is labeled as A, B, and C, and the extent of the dissection was labeled as less than 180 degree and more than 180 degree. And for instance, in this particular, IVUS image, you can see the media is involved and the arc is less than 180, so we classify that as a B1. So if you look at an angiogram following a treatment, this is a fem-pop segment treated, you see virtually no dissections on the angiogram. When you start looking into by IVUS, we have 5 dissections identified by IVUS involving the intima, the media, as well as the adventitia. In other words, perforations, and you just do not see them really on an angiogram. And if you look the same thing in the infrapopliteal territory, beautiful angiographic results, very significant dissections. Even in the infrapopliteal segments, we have IVUS is uncovered 3.8 times more dissections than we have seen on the angiogram. So precision imaging is important for vessel prepping. It will help us identify the plaque morphology, the choice of the debulking device, and the degree of debulking. It help us decide on what dissection we need to repair, better sizing to get better minimal luminal area, and better choice to the size of the DCB. Is our DCB failing because we're undersizing? That's always a question we have to ask. I mean, we're undersizing by a good millimeter to 1.1 millimeter. So with good sizing, maybe we will have good apposition, good drug delivery, and hopefully leaving the minimal residual narrowing. So some of the data in IVUS and below the knee, you can see that from Fujihara's data in 2014. It's a retrospective single center, but showing clearly that larger balloon diameter are used when you use IVUS, and better post-procedural perfusion and better wound healing, as you can see in this plot. Also data from SOGA, single center retrospective, below the knee, in limb ischemia patients. Again, exact same data. Larger balloon size was used when we use IVUS. You had better wound healing and faster wound healing. And in this case, there was higher limb salvage in this paper. If you look at a meta-analysis of over 93,000 patients, including all type of lesions, including below the knee, there was significantly lower risk of periprocedural adverse events and vascular complications with the use of IVUS. So clearly in these retrospective type of data, we have a signal that the use of IVUS can make a big difference. Reduction in the major adverse limb event, using bigger balloon size, less complications, more identification of dissections, amputation reduction. Still, we do not know the impact of this on PLR and patency. What about OCT? OCT is limited by 1 to 3 millimeter depth, the penetration depth, and that may not be suitable, maybe for some tibial vessels. You could do it much faster. You can have the frame rate almost 100 frames per second. The pullback is 30 to 40 millimeter per second, which is way more faster than an IVUS. And it's excellent for thrombus and calcium. However, you can see that the measurements of the lumen, the vessel diameter, the vessel area is not different from IVUS at all. It has better ability to characterize, the plaque itself and the presence of calcification. But for practical purposes, and we don't have a whole lot of labs that have OCT around, I think IVUS is a very good tool to have and a good substitute. Now, this is the IVUS expert consensus that was just presented at Viva. I think this is a very important work, the steering committee and the writing committee. We have several of them here on the panel. And as you can see, the focus of this consensus panel was to look at when do you use IVUS, pre-intervention, intraprocedurally, or procedure optimization, and in what territory you use it, and how often do you use it. A lot of centers were involved, radiology, vascular surgery, and the cardiology were involved in assessing this. And the conclusion was very simple. IVUS strongly supported for use during lower extremity arterial and venous intervention. In the iliac, SFA, and POP, most of the consensus was it's great to use intraprocedurally and post-procedurally, whereas for tibial intervention at all phases of the procedure, before, during, and after, the consensus agreed that this is what we really need to do. And of course, for venous application, it's all supported for procedural phases. Again, the effort here should be to implement more IVUS into our practice, because there's a very good chance it may make a big difference, in the outcome of our patients, especially in the tibial territory. I think this is my last slide. Thank you very much.